Now, in the evaluation of patellofemoral instability, I think it's important to know how the patella can move. So, of course, we know it can move medially and laterally. It can rotate. It can tilt medially and laterally. And it can also tilt proximally and distally, although we don't talk about that as often as we do the medial lateral and the medial lateral tilt. For the clinical examination, obviously you would reduce this first. It's important to assess ambulation and gait, document the presence of an effusion, because that can also give you a sense of what else might be going on. A lot of times if they don't have an effusion, it could be more chronic in onset, looking for any sort of other signs of acute trauma, bruising, checking the range of motion is important, and of course, a good ligamentous exam is critical in these cases because, as many of you know, a big hemarthrosis in a patient could be a patellar dislocation, but it could also be an ACL. So you don't want to just assume, just because the patient felt something shift and they thought it was their patella, that it wasn't their ACL. You want to really make sure that we don't miss anything else. The apprehension test, this is really important. So at about 20 to 30 degrees of flexion, you translate the patella as far as it'll go, both medially and laterally. And if the patient feels that it's about to dislocate, then this is, you can assume that there is some sort of instability component involved. Now with this, it's important to know that you can also have pain. So pain with translation is not a positive apprehension test. It really has to recreate their sense of instability, and you have to know which direction it is because there is an entity called medial patellar instability, which is not common, but it can happen. And what you don't want to do is just check laterally and completely miss this entity. This typically happens in patients who have had a prior lateral release, and it's the exam part of this is, and I think with anything related to patellofemoral, the imaging is not always going to show the findings. It's not going to, get an MRI, and it's not going to tell you you have medial dislocation. And so you have to really rely on your clinical exam. What I found is that with medial instability, you can actually get your thumbs like right into the trochlea there. But because the medial condyle is lower than the lateral condyle, you're not going to feel that big clunk that you get with the lateral dislocations. And so this can be easy to miss.